Welcome to this special series of Diabetes Core Update, where we will discuss heart failure with preserved ejection fraction, HFpEF. At least half of all patients with heart failure have HFpEF, but it's really only in the last few years that we've seen the development of effective therapies for HFpEF. We've also found out it's a lot more common and important than we used to think it was. I'm your host, Dr. Neil Skolnik, professor of family and community medicine at the Sidney Kimmel Medical College of Thomas Jefferson University. In part one of this series, we will discuss the epidemiology of heart failure with a focus on HFpEF, pathophysiology, staging, and something that a lot of people are not yet aware of: screening. Yes, I said screening. Our experts will discuss the rationale and recommendations for screening that are now part of the ADA's standards of care. This series is being sponsored by Roche. Joining us today to discuss HFpEF, we have two experts in the field. Dr. Radhika Busai, MD, PhD, is professor and chief of the Division of Endocrinology, Diabetes, and Clinical Nutrition, and director of the Harold Schnitzer Diabetes Health Center at the Oregon Health and Sciences University. She was the 2023 President for Medicine and Science of the American Diabetes Association, and is an internationally recognized leader in the field of diabetes and diabetes complications. Her research interests involve chronic complications of diabetes, including diabetic neuropathy, diabetic foot complications, diabetic kidney disease, and what we're talking about today, heart failure. And she was chair of the landmark consensus report from the American Diabetes Association titled Heart Failure, an underappreciated complication of diabetes. We're privileged to have her join us. Radhika, welcome back to our podcast.
Thank you very much, Neil, for the very kind introduction. It's truly a pleasure to be here today, sharing the stage with you and with Jim, and I look forward to it.
Thanks so much. And also joining us today, we're privileged to have Dr. Jim Januzzi. Dr. Januzzi is a professor of medicine at Harvard Medical School, a cardiologist at the Mass General Hospital, and chief scientific officer at the Byam Institute for Clinical Research. He has published more than, get this, 900 manuscripts. I don't know how Jim, how you do that. We were talking about that earlier. He has edited 5 textbooks, and he is a deputy editor at the Journal of the American College of Cardiology. He lectures nationally on biomarker testing and was one of the early researchers in this area, as well as lectures on the treatment of heart failure. Jim, welcome.
Thanks for having me, Neil. It's really great to be here.
Jim, can I ask you to start by helping us understand what HFpEF is, that's heart failure with preserved ejection fraction, what it is, and why we should care about it in both primary care and general endocrinology practices?
Yeah, thanks for asking. And it's really great to see an increasing focus on the diagnosis and care of heart failure with preserved ejection fraction. Traditionally, people viewed heart failure through the lens of those patients that had reduced cardiac function, so-called heart failure with reduced ejection fraction. We assess the squeezing strength of the ventricle using, say, echocardiography to categorize patients this way. But it's become quite evident that a substantial, if not dominant, percentage of patients who have heart failure, defined as an inability of the heart to provide the necessary output to sustain normal function, actually have a normal squeeze to their left ventricle. So we, I think, for many years underappreciated just how common heart failure with preserved ejection fraction may actually be.
Yeah, I think you're right. And it's impressed me just clinically since it's become a more common part of our lexicon.
Yeah, that's correct. And that's both because the very symptomatic forms of heart failure with preserved ejection fraction are becoming more common as the population is aging. So HFpEF, as we call it, is very age dependent. So with the aging population, we certainly are seeing it more. Additionally, we're getting better at caring for other forms of structural heart disease, which therefore allows for the final common pathway of all these various diagnoses, valvular heart disease, arrhythmia, coronary disease, to manifest as heart failure, more often than not with preserved ejection fraction. Furthermore, the epidemic of obesity, dysglycemia, and frank diabetes also all conspire to intersect and lead to heart muscle disease. So for those reasons, we're seeing more HFpEF. But then also, as I said, it's increasingly on our radar. And so we are now recognizing that, in fact, the diagnosis may be present even in people who are minimally symptomatic and yet are quite limited if you, for example, do a stress test on them, really indicating how insidious the diagnosis may be, and really emphasizes the importance of earlier diagnosis because we do have tools to treat it.
Yeah, it's a really good point when you talk about insidious and how subtle the diagnosis is. I don't think many of us would miss it if someone comes in and they're complaining of significant shortness of breath, they have RALs on exam, they've got a lot of edema in their legs. That's not a challenge. But we'll talk about staging heart failure in a little bit, but in the early stages of heart failure, someone can just have some, I think New York Heart Association stage 2 or class 2 is dyspnea on exertion, doing usual activities. Is that correct? So when I see someone in the office, I hate to say it, but a lot of people over 50 who are a little bit overweight and aren't exercising regularly might fit into that symptomatic classification.
Exactly. There's a great overlap between what people view as normative aging or deconditioning, but the truth is that it's not normal, and there are great examples of how insidious this diagnosis can be. I'll give you one. We recently finished a clinical trial in people who had a diagnosis called diabetic cardiomyopathy. This is a form of HFpEF that is caused by diabetes in the absence of other established reasons for heart failure. These people were supposedly asymptomatic. They had no prior diagnosis of heart failure. And in fact, on questionnaires, had very high function in their quality of life scores. So from their perspective, from the perspective of the patient, they were fine. They had no complaints. And yet, when we did cardiopulmonary exercise testing on these people, this is a very highly specialized test to assess exercise capacity. The average peak VO2 in these patients was in the range of people that we often see in the heart transplant clinic, really illustrating how incredibly limited someone may be and not recognize it, or at least be in denial about it, and emphasizes the importance of using tools to better understand the presence of heart failure in these folks.
Boy, that illustrates that point so nicely, because the reality is functional people adapt to their situation, and people often restrict activities so as not to provoke symptoms, but those deficits are there. What an amazing example. Jim, can you go on now to briefly go over the pathophysiology of HFpEF?
Sure. So the pathophysiology of HFpEF is complicated because, unlike reduced ejection fraction, which is heart failure, which is largely driven by the loss of squeezing strength of the heart, HFpEF may be caused by a number of different factors. We've arbitrarily called HFpEF so-called diastolic heart failure because, to some extent, but not entirely, the pathophysiology, when the ejection fraction is normal, is not about the squeeze of the heart, but in many cases how stiff the heart is on relaxation. You can see this in people with diabetic cardiomyopathy, hypertensive heart disease, so-called restrictive cardiomyopathy. And among individuals who have obesity, the presence of both epicardial LDL and pericardial fat can actually be a restriction to the heart as it relaxes. And so the presence of obesity is one of the major recognized emerging risk factors for the HFpEF epidemic that we're seeing. There are other causes to consider as well in persons who have diastolic heart failure or HFpEF, including the presence of valvular heart disease. So the squeeze is fine, but because one of the valves is not working well, a person develops heart failure. Arrhythmia, in particular atrial fibrillation. But importantly, Neil, think about this as a clinician. There's a gross overlap between all of these various diagnoses. So sometimes it's hard to identify the single cause of heart failure in our patients. A person may have obesity causing sleep apnea, which leads to atrial fibrillation.
Mm-hmm.
They may have obesity that leads to restriction of the heart and diastole. All of these factors conspire to develop heart failure, and illustrates why it is so important when we treat these patients to address all of the factors that may be causing heart failure in their case.
So important to understand. Radhika, when we think about the complications of diabetes, we always think about atherosclerotic heart disease. We think about microvascular diseases, chronic kidney disease, neuropathy. Can you talk about whether we should also view heart failure as one of the complications of diabetes? And if that is the case, why we should think of it that way?
Well, thank you so much, Neil, for this great question. And I also want to say that it is really remarkable to, listen to such a very elegant explanations on these various mechanisms lead to the presence of heart failure in people with diabetes. And before I go to my actual question, I'd just like to highlight a couple of other mechanisms that are, very relevant for diabetes that further contribute to the development of HFpEF. And one is the autonomic dysfunction, which is actually a form of neuropathy that affects the autonomic innervation of the heart. This has been driving in many people with diabetes, as we and others have identified in large cohorts with both type 1 and type 2, this additional dysfunction that is associated with HFpEF, because the autonomic innervation is the primarily extrinsic mechanism that regulates cardiac contraction, as well as the microvascular dysfunction. And granted, both of these two, mechanisms have been historically harder to identify through, our usual diagnostic measures. However, the progress that we have made now enable us to visualize both the sympathetic and parasympathetic imbalance in the heart, as well as the microvasculature in the heart. And then getting back to your question, absolutely. In fact, we, Jim and I, were chairs and co-chairs of this heart failure consensus paper. And that gave us an opportunity actually to truly study the epidemiology of heart failure in diabetes. And we were very fortunate to have access to large epidemiological cohorts across the world, and identified that contrary to the common paradigm for many years that atherosclerotic cardiovascular disease is the primary cardiovascular complications in people with diabetes, in fact, heart failure, particularly heart failure with preserved ejection fraction, seems to actually be now taking the center stage. So that's one argument here, and that has been documented, as I said, in large cohorts, including the CCT-ERIC, arguably the most, thoroughly phenotype cohort of people with type 1 diabetes followed for more than 40 years, but definitely in many other cohorts, including in Europe, the Swedish and Scottish registries, and many others. So clearly, the prevalence of heart failure in diabetes cannot be ignored. In addition, as I mentioned, there is a very strong link between kidney and actually the autonomic neuropathies and heart failure. These vicious cycles that is present in people with diabetes who have even earlier stages of chronic kidney disease and its impact on these various mechanisms that lead to a progressive, dysfunction, further contributing. And thus, we should include heart failure as one of our focus and target when we evaluate people. What I would like also to say is that we were able to see that people with type 1 diabetes may have an even higher risk of developing HFpEF, and particularly women. So that is opening additional fields for both targeting individualized care in our daily practice, but also for research discoveries.
Jim?
I think Jim wants to.
Yeah, so I just wanted to affirm and emphasize just how important a couple of things that Rodica said. I mean, first of all, there are differences in people who have heart failure, with a proportionally larger percentage of women that are affected by the diagnosis. And again, to the extent that this diagnosis may present in subtle ways, the delays in diagnosis owing to under-recognition in women, I think, is something that we definitely have to pay more attention to. In addition, gosh, I cannot agree more, and I should have mentioned this earlier. This was sort of a facepalm moment. The intersection of chronic kidney disease and HFpEF is overwhelming. I will tell you that, particularly as a cardiologist, I have started measuring urinary albumin creatinine ratio in my patients because the presence of diabetic kidney disease is essentially a one-for-one for the presence of HFpEF. So if a person has elevated UACR, particularly as the concentrations are higher and higher, the likelihood, even if they don't know it, that they have underlying structural heart disease rises as well. So this is really important because my world, therapeutically, overlaps dramatically with the diabetes world in terms of the tools that we use to treat all of these various diagnoses.
That's so helpful. And, as we begin to think about this, there are groups that we're going to talk in a minute about the screening recommendations for all people with diabetes, but clearly there are some where that rises up even more. It sounds like people with CKD and diabetes would be one, who have obesity and diabetes, longstanding hypertension. All of those things add to the level of risk. Rodica, we know that when we think about CKD or neuropathy, glucose control is an important part of prevention. Is that also relevant for heart failure?
Well, wonderful question. And I guess we can elaborate a little bit on this one. We know from an epidemiological standpoint that glucose is a very important risk factor for the development of heart failure, even in the pre-diabetic stages. And as Jim alluded, and you have alluded to, we see that heart failure with preserved ejection fraction is so prevalent in obese population who may also have prediabetes for reasons and mechanisms that have been already outlined. I think that clearly both in type 1 and type 2 diabetes, glucose as a, time dependent has been shown to clearly exponentially increase the risk for developing heart failure. Do we have evidence that aggressively treating glucose does reduce the risk of heart failure? I see that here the data is a little bit more complex to, tease out. So in DCCT, the same cohort that I mentioned, which is, very well, Neil, was in fact the reason that we have standards of care in diabetes, and we have been able to even benefit of all these amazing tool of new medications that have been developed in response to the evidence that intensive glucose control can prevent chronic complication, including cardiovascular disease. So definitely in DCCT, we have seen that intensive glucorol applied early in the course of the disease in a young population that obviously didn't have high risk factors, years later did have an effect of reducing the incidence of the main cardiovascular outcome that was a composite. And more recently, heart failure has been added to that composite. For instance, when we looked at 30 years of follow-up in this cohort, we saw that glucose, in fact, was the strongest risk factor for developing this composite, which also included hospitalization for heart failure. Now, we also have to look at the data with the SGLT2 inhibitors that have been developed initially to treat glucose and have been initially used in people with type 2 diabetes and had a significant effect on reducing heart failure, including hospitalization and heart failure associated. That granted, glucose was not actually the primary mechanism that explained that reduction in risk. But the question wasn't necessarily asked along those lines either, because, as you know, these agents were added compared with the standard of care, and in both arms, a certain degree of glucose control has been expected by trial design. So no, we don't have the same evidence in type 2 diabetes as we have in type 1 diabetes that highlights the importance of glucose control, but we do know in type 2 diabetes that glucose control is important to prevent chronic kidney disease, and that has been also amply documented. And we just have highlighted the link between CKD in diabetes and heart failure. Thus, we do have an argument to maintain as appropriate and as, good glucose control in our patients, regardless of they have type 1 or type 2.
That makes sense. And then any other addressable risk factors at a high level that we should be aware of?
Yeah, well, definitely obesity. And we have just witnessed this year only that in one larger obese population, which was the SELECT trial, who did not have diabetes. In fact, this new class of agents, GLP-1 receptor agonists, have been associated with a significant reduction in the risk of a strong heart failure composite outcome, which was hospitalizations for heart failure or heart failure associated with that. Of course, with almost 20,000 participants enrolled in that trial, during follow-up, there was the opportunity to actually confirm data that have been shown earlier with the same agent, semaglutide, and symptoms associated with neuropathy. And in fact, I think that just Saturday at American Heart, the tirzepatide data has been released, mainly for worsening of heart failure. It was a smaller cohort, but demonstrating clearly that this class of agents have benefit on heart failure outcome. And the same is true with the SGLT2 inhibitor. If we think about it, the most recent SGLT2 trials did not include necessarily people with diabetes, but a majority of them were in fact obese if we looked at their baseline characteristic and their BMI. So that's an important risk factor that needs to be addressed. Clearly, as Jim already mentioned, hypertension is an important risk factor. And another aspect that we identified doing the when we were evaluating the data for the consensus, which was very strongly associated with worse outcomes and higher risk of developing heart failure, were the social determinants of health, because these components, access to care, level of education, income, access to housing, food security, social support, in fact, all contribute to a patient opportunity and capability to have access to the care that they need, even to address their diabetes control and prevent other complications that are and other risk factors, including the one that I have just mentioned, that are so essential in both the development and then progression of heart failure.
It's so helpful and all critically important issues. Jim, let me now turn back to you, and we're going to discuss treatment in a future podcast on HFpEF. So today we're setting the stage for diagnosis and screening. And in doing so, earlier we discussed the classification of heart failure by ejection fraction. But can you go over for us now the stages of heart failure? And that's important because I think it's important for our audience to understand there's an asymptomatic and also, as you alluded to earlier, a mild early symptomatic stage where it's so easy to miss the diagnosis unless we're screening for it. So stages of heart failure.
Sure. Yeah, absolutely. And understanding the staging of heart failure is critical to discuss then the idea of early diagnosis. I don't like the term screening because what that implies is that you're sort of fishing, but this is a highly prevalent diagnosis. And so the issue here is it's not so much identifying the needle in the haystack so much as sorting out the many patients that have the diagnosis and judging how severe it may be. So heart failure, like many things in medicine, is staged in 4 steps. We previously would evaluate people on the basis of the presence of symptoms, but it turns out that heart failure often has a very long pre-symptomatic phase. So we now consider symptoms, the New York Heart Association symptom severity, but that's in the later stages of heart failure. Stage A heart failure is really covers essentially anyone who has diabetes, but then also many of the other potential risk factors for heart failure. So stage A is an asymptomatic at risk for heart failure without any evidence of cardiovascular dysfunction at present. So a person who has diabetes would have stage A heart failure. A person who has hypertension, much as I do, has stage A heart failure. The idea behind this is if you know you have a risk factor, it argues for control of that risk factor, which to me is aspirational because unfortunately we know that in the general population, control of risk factors like high blood pressure or glycemic control still has a long way to go before we can really say that we're meeting the goals that we set out. Stage B heart failure is a crucially important population to understand. These are people who do not have present or past symptoms of heart failure, but are found upon testing to have underlying cardiac dysfunction. That testing may be evidence for cardiac changes on echocardiography, enlargement of chambers, reduced ejection fraction, abnormalities in diastolic relaxation. But in addition, stage B heart failure may also be identified through the presence of abnormal biomarkers of cardiac stress. So elevated concentrations of natriuretic peptide, elevated concentrations of high sensitivity troponin. These abnormalities in biomarkers have repeatedly been associated with a high likelihood for progression to symptomatic stages. Those are stages C and D. And that's where the New York Heart Association symptom severity lives, in the symptomatic stages. The idea by thinking of people in these stages is it puts a really important focus on recognizing that this is a long journey from risk factors to end stage, and there's plenty of opportunities along the way to recognize the diagnosis and intervene.
It's so helpful, Jim, and I think you discussed that progression so nicely because I don't think that is that well appreciated among primary care and endocrinology clinicians. And Radhika, that really sets the stage nicely for discussing the consensus report that both you and Jim were a part of. And that was, I also want to say, that was a joint report by ADA and the American College of Cardiology. It was published in Diabetes Care in 2022, but as such, it carries a lot of weight. And I know there was a lot of work and careful evaluation of the evidence that went into those recommendations. Can you tell us about the rationale and recommendations for screening that came out in that consensus report?
Absolutely. I think that one of the main goals of the consensus was actually to provide guidance to clinicians outside the cardiology realm, because obviously that was not our scope. Cardiologists know very well how to diagnose and treat heart failure, but because diabetes is such a prevalent, chronic disease, and obesity as well, we wanted to target those clinicians that are most likely to be in the front lines first, treating or, and helping those patients. In addition, we were fortunate that at the time that we, started to work on the consensus, a very large body of evidence has emerged demonstrating that now we do have very sensitive and powerful tools to diagnose these patients as early as Jim mentioned earlier, even before they develop overt symptoms, because evaluating and diagnosing a disease early is obviously poised to enable much more effective management strategies. Concomitantly, we were also very fortunate to have now effective medications to give to these patients that have been shown to be effective to prevent, more advanced stages of heart failure, including hospitalization and then death. And so with that background information, our goal was, let's provide a practical tool that can be easily implemented in a very busy clinical practice. We were very mindful and continue to be how burdensome is to provide care these days due to a variety of reasons, particularly the primary care physicians who have to deal with a lot of diseases, a lot of screenings, and that the same is true in endocrinology. We also wanted to convey the message that treating and preventing cardiovascular complications, particularly heart failure, it's not, the property of cardiologists or of endocrinologists. It can be done effectively only with a team approach, and implementing these screening strategies, including the natriuretic peptides and the high sensitivity troponins, is easy to do today. And that's exactly what we have recommended in the consensus, providing an algorithm on what would be the main characteristic of people that should be considered for screening. Again, we wanted to make things as easy as possible to clinicians, and then how to do it. And when it's done, what to do with a given lab test.
So if we look at all of our patients with diabetes, what were the recommendations? Who should we get a BNP or NT-proBNP on?
So every person with diabetes, and we specifically said that both type 1 and type 2 for the reason that we both have alluded at. And then, there are 40 million of people with diabetes in US as we speak. We definitely cannot screen them all. But what are additional documented risk factors? Well, definitely age, it's one. As Jim mentioned, aging is one of the risk factors for HFpEF. Presence of chronic kidney disease, even in earlier stages, and it can be identified through an eGFR and urine microalbumin. Obesity for sure, so a BMI above 30, and presence of hypertension, whether it's treated or not, again, an important risk factor. So those are some of the main phenotypic characteristics that we have identified that would warrant including in this, preventive screening approach.
So we order the test, and we'll talk in a moment about what the next step is. And then the other question that comes up frequently is how often? Because some tests are one time in a life screening, some tests are annual. For this, the recommendations were?
So what we said is that we would screen, and then based on the values, we also have recommended that if it's normal, a rescreening should be done again in 12 months, evaluating, all these large data of trials that many of which Jim was part of, and understanding what would be the risk of, a test becoming abnormal in this type of patient population. And if it's abnormal, of course, we have an entire set of recommendations, provide uniform guidelines.
Jim.
Yeah, so wonderful summary. And I think it's important for your listeners to understand that unlike certain tests that are a one and done, the natriuretic peptides and troponins both have been shown to track with the presence of, but also the development of the disease. And so a person who has a normal measurement, and we should probably emphasize here that the levels that we're talking about with these biomarkers are considerably lower than what are used when a person presents to the hospital with, say, acute severe shortness of breath. We use much higher cutoff values with the natriuretic peptides in particular when we're looking for acute heart failure in the emergency department. But when we're using them for early diagnosis in the, say, the outpatient setting, the values are 10 times lower than what we use in the emergency department. So clinicians need to understand that, a modest elevation in these tests that are not even outside of the quote normal range that they're used to seeing may actually flag a patient as being at risk. Furthermore, the serial measurements over time have repeatedly shown that a person who rises over time has a high risk for short-term development of heart failure. And conversely, we just published data from Look Ahead, a study of lifestyle intervention for diabetes, that a falling natriuretic peptide in association with the lifestyle intervention was associated with improvements in risk. So these secular trends over time are important, which is why we recommended at least yearly measurement.
That it could improve with lifestyle is so exciting. What is the cutoff? What number should we be looking for? We're getting close to the end of our podcast. So, Jim, if you can address three things. One, what number should we be attentive to as that lower cutoff you mentioned? Mm-hmm. Two, are there certain things that influence the number that we need to be mindful of? And then when the screening exceeds that number, what's our next test?
Sure. Okay. So the first two questions are highly interrelated. What number should we be looking for? Let me just focus on NT-proBNP because that's where the majority of outpatient early diagnosis data are. With N-terminal proBNP, the current recommended threshold value is 125 nanograms per liter. Again, some 8 to 10 times lower than what we use for acute heart failure, right? So when you see someone with an NT-proBNP above 125, that's actually fairly abnormal actually in the general population. However, there are caveats. We know that the presence of obesity results in lower values of natriuretic peptide. Biology is complicated, but it relates to a suppression of BNP expression. So persons who have obesity and lower natriuretic peptide values may still have heart failure. And so therefore, when looking at someone who has obesity and you're measuring a natriuretic peptide, a value of NT-proBNP down even under 100 may identify someone as being at risk for heart failure. On the other hand, the presence of other cardiorenal risk factors, atrial fibrillation, chronic kidney disease, these may cause higher values of natriuretic peptide, but I would emphasize that in a person who has AFib or chronic kidney disease, if they've got a higher natriuretic peptide value, you should go to step 3 of those 3 questions you asked me and look for the presence of heart failure. And what do? This is actually well established at this point. Taking a step back and assessing cardiac risk factors, control of heart failure risk factors, not just glycemic control, but how sugar is controlled. You're going to talk about management subsequently, but clearly it's not just glycemic control, but how you control it. And then lastly, advanced imaging tests to evaluate for the presence of heart failure. Now, echocardiography is not so difficult to get. It's not highly complex, and that would be the next first step. There may be other things that we need to think about and look for, other types of imaging and other types of testing, but the simple answer is get an echo and go from there.
That's great. And I love clear, straightforward answers that let us take action in a clear way. Obviously, we do the screening for a reason. Once we identify patients with HFpEF, there are a range of treatments available that we're going to talk about in subsequent podcasts. We're about out of time. Jim, are there any final thoughts that you'd like to share with our listeners?
Well, first of all, I'm extraordinarily grateful to the American Diabetes Association, to my colleague, Dr. Busui, who has been so amazing in her focus on the critical intersection of diabetes and heart failure. It's exciting to see that our worlds are working together. As I've already said, the tools that I use are the same tools that people that treat patients with diabetes use, the same meds. And so we have a real opportunity to collaborate to improve the outcomes of patients with this increasingly prevalent diagnosis.
Thanks so much. Radhika, your final thoughts for our listeners.
Well, I would also like to express my gratitude to both the American Diabetes Association for enabling us to actually work on the consensus, as well as to Jim, who has been a phenomenal partner and guiding us with his perspective and making sure that we provide the clearest and having access actually to some of the evidence that was so critical to, result in this recommendation. My thoughts are as well that it is very important to make sure that now we disseminate this information as effectively as possible to enable clinicians to be comfortable to actively screen these patients, because the rewards from a patient perspective, but also from health care delivery, are immense. We can make a difference. We can now actually stop the progression of this lethal disease, because we have the tools to identify these patients very early in their course, and we have now the strategies to reverse its course. And we actually have a lot of evidence, as Jim had said, that by doing that, we can indeed reverse course. So now we still have work to do, and I'm very grateful that Jim and I are continuing to work together. And I'm also very grateful again to ADA and to you, Neil, because this podcast will help us further disseminate this message. And hopefully we will engage all clinicians that provide care to people with diabetes to take action as early as possible.
So important. We live in an exciting time with so much that we can do. We have to communicate it, disseminate the information so we actually do it. Dr. Radhika Busui, thank you so much for joining us.
Thank you so much. Wonderful being here with you and Jim.
Dr. Jim Januzzi, thank you so much for joining us.
Really appreciate the opportunity to speak with you today, Neil. Thank you so much.
And most of all, as always, thanks to our listeners. Thank you for joining us on this first of a multi-part series on early detection and treatment of heart failure with preserved ejection fraction. In the first part of this series, we focused on basics, epidemiology, pathophysiology, and staging, as well as the critically important new recommendations around screening people with diabetes for heart failure. In the second part of the series, we're going to talk in detail about treatment. These special editions of Diabetes Core Update are sponsored by Roche. We thank you for listening, and for the American Diabetes Association, I'm Dr. Neil Skolnik. Till next time, stay safe and keep learning.